everybody. Thank you, Jane. You picked a great meeting to attend, as always, but this one is special. So I'm especially happy to see Merle Green, and I'd like to welcome you, Merle. Thank you so much for reviewing the things we put out and contributing to our success.
Absolutely. It's my pleasure. You all are a hardworking, focused group, and it's always.
Thank you. Okay, well, may I have a volunteer to take notes? Thank you, Wayne. Appreciate that. And let's just get right down to business. We have a guest today, a very special guest, Dr. Elizabeth Tilson. Dr. Tilson serves our state as the health director and chief medical officer for the Department of Health and Human Services. In this role, she promotes public health and prevention activities, as well as provides guidance and oversight on a variety of cross-departmental issues, including the opioid epidemic, early childhood, Medicaid transformation, and healthy opportunities. Most recently, as you can imagine, her work has largely focused on fighting the COVID-19 pandemic. Dr. Tilson received her BA in biology from Dartmouth College. She earned her MD at Johns Hopkins University and a Master of Public Health from UNC Chapel Hill. She completed a pediatric residency at Johns Hopkins and a general preventive medicine and public health residency at UNC Chapel Hill. She is board certified in both fields. In prior roles, she served as the Medical Director of Community Care of Wake and Johnston Counties, Chief Network Medical Director for Community Care of North America, Assistant Consulting Professor and Cancer Control Specialist with Duke University Medical Center, and a Clinical Pediatric Fellow at UNC Chapel Hill. Dr. Tilson practiced primary care pediatrics for 26 years, primarily at her local health department, Wake County Human Services Child Health Clinic. She has been active and has served in leadership roles in many local, state, and national pediatric, public health, and preventive medicine organizations. We are very lucky to have you, Dr. Tilson. We appreciate that very much. And we also appreciate your willingness to let us record your presentation so we can share it to a wider audience. So I will turn things over to you.
Terrific, thank you. And I'm really happy to be with you all today. And since it's a relatively small group, also happy for this to be very much a dialogue. I do have some material I wanted to present to you. I have some slides. I'm happy to do questions after, or even if folks want to interrupt me as we go forward, happy to do that and just take advantage of this a little bit smaller and more casual setting. So happy to do whatever is of the best service to you all. Also, just really want to thank you for your interest, for your advocacy, for your engagement in being part of our citizenry, and just having engaged folks and informed folks is just so very important. So really grateful for this dialogue and for your invitation and for your interest. All right, I am going to share my screen. I was told I had that power, so I'm going to do that. And then I also, oh, hold on, you probably don't need to see that Word document that I'm working on. Okay, so let's see, Merle, I see your face. Can you see my screen?
Absolutely.
You can, okay. And then if I do this though, I think, hold on, I think I need to switch it over. Okay. Is that good?
Yes.
Okay, perfect. Takes a little bit of nuance. I'm learning. Wonderful. Great. Well, what I wanted to briefly go over was our priorities going forward, especially as part of recovery for COVID, and really our emphasis on whole person health and how we're trying to bring that concept to life. So what I thought I would go over is just three main areas. One, just a little bit about the current status of the pandemic and how we hope we're in a different phase of this pandemic, which is really nice, and then allows us then to look forward to recovery. So I wanted to talk through some of our priorities for recovery, and then talk through again a little bit of how we're really trying to pragmatically operationalize this concept of whole person health. And I'll be talking through some of our statewide infrastructure we're building and a little bit of what we're incorporating within Medicaid, because that's a really great way to operationalize and finance whole person health. So I'll touch base on those concepts as well. Okay, let me start first with where we are with the pandemic. As you heard in the intro, it is true that for the past two, almost half years now, almost the entirety of our focus and our work was around responding to the COVID pandemic. We have really been in crisis response mode for almost 2 years, continuing trying to address the pandemic as it changed, trying to address the disparities that the pandemic was impacting our population, and have been really, again, being in that response and crisis mode. However, we do think that we now thankfully are in a different mode of our COVID-19 response. So out of that crisis response mode, more into disease management, into living with COVID, as opposed to trying to respond in a crisis mode. We have and you can see this, the web link on the bottom left of the slide. We did put out a paper just about a month or so ago that describes moving forward into the next phase of the pandemic. I really encourage you to look through that document. It's only about 4 or 5 pages, it's not that long, but it really describes why we're in a different context now, why we think we can move into this different phase. One is that we have a lot more tools now that are readily available that we didn't have in the beginning, or that were short supply as we moved through the pandemic. So we have readily available vaccines and boosters, much more readily available testing, much more readily available treatment, especially for those folks at highest risk of severe complications from COVID, and much more personal protective equipment with masks and those pieces that were in short supply earlier on. So very different context in terms of the tools that we have that people can utilize. Second, we have a lot more, we say, immunity in the community. From either vaccinations or boosters, and or people who've had the infection. If you look at that across the population, we have much higher levels of immunity. Now, that doesn't mean that an individual is not at risk of getting infected, even if they're vaccinated or boosted, and even if they've had a past infection. But it does look, when you look at the amount of immunity across the population, when you're starting seeing much more higher levels of immunity, it tells you your risk of this really skyrocketing in a population is blunted by that level of immunity in the population. And so we have some data, we have data from people, for adults that donate blood to the Red Cross. They're able to look at antibodies in that donated blood, and they can look at antibodies that are a combination of both from vaccines and from infection. In North Carolina, about 97% or so of adults 16 and over have some immunity, again, either from vaccines or past infections. There's another database we can look at of, for all people, including children, looking at immunity or looking at antibodies from past infection. And we just got some data that about 60% or so of our population has some evidence of antibodies from past infection, and actually pretty high amongst our pediatric population. About 75% or so of our pediatric population have evidence of some infection. So it just tells us that when we have that high level of some antibodies, it helps to blunt the severity of the disease as it spreads across our population. And all of our key trends are down as well, which is really nice. And we're going to see some ups and downs. We're going to see some upticks, but overall, our trends are in a much different place than they were when we were really surging in some of those past peaks. And so when we think about the next phase, what does that mean? It means now we can shift more from some of our blunter public health governmental mandate tools. In the beginning, that's what we had, and we had to apply those more blunt tools. Now we can move towards more refined tools and really thinking about empowering individuals and making sure individuals have the knowledge and the tools that they need to make those decisions to protect themselves and their family. So that really is a piece of moving from crisis response in these blunt public health measures to this more disease, living with it, and disease management is really allowing and empowering our individuals to make those decisions. We're going to continue to prioritize equity as we've always done throughout the pandemic, making sure that everybody has equal access to all of our tools, and especially ensuring that our populations that have higher risk of infection, higher risk of severe disease, ensuring those folks have equal access to all these protective tools. We're going to keep our eye on maintaining our health system capacity. Thankfully, although we got close a couple times, our health system capacity was never eclipsed. And that was a really, really important goal for us as we moved forward. And continuing collaborating with all of our local partners, including our local health departments, which have been one of our key local partners. So those will be some of our principles. And then we're really thinking about our operational preparedness and what do we want to be sure we have in the state to deploy if needed. One, our data transparency. We've really from the beginning have had a very robust data dashboard. We really tried to have our data transparency be as robust as possible. I'm going to show you on the next couple slides some of the new measures and metrics that we're tracking that is on our data dashboard that we were happy for you to follow along with us. Again, we're continuing to work with our health systems to make sure they don't get into trouble in terms of their capacity. We're going to make sure that we have sufficient and easily available supplies of vaccines, testings, and treatment. And then we'll continue to work, especially closely with our local health departments for outbreak management, especially in high priority settings like some of our nursing homes, our long-term care settings. So those are areas we're moving forward to be sure that we are prepared and able to deploy our resources as quickly as we need, which is something we didn't have in the beginning of the pandemic. We didn't have vaccines, we didn't have testing, we didn't have treatment, we didn't have stockpiles. We are ensuring that we have all those stockpiles. So if and when the demand increases again, we can deploy them very, very quickly for people. Okay, and just a little bit of a turn towards our new metrics. Again, in this new phase of the pandemic, we also looked at what metrics we have and refined our key metrics that we are looking at to help us plan our priorities and our activities going forward, but also to make sure that individuals know what the status of COVID is in North Carolina, so they can think about the context as they are thinking through those individual decisions of how many layers of protection do I want to apply to myself or my family members. We really want to be sure people know of the data around, and this is on our publicly available dashboard on our DHHS website. So we have two key indicators that are early warning indicators. It gives us a sense of, are we starting to see some upticks, and can give us, again, a little bit of an early warning that overall, sometimes we can see movement in this about a week earlier than some of our other metrics. And this is, it's not unique to North Carolina, but all states don't have this capability. We're one of a few states that have this robust early warning indicator. So we have a network of wastewater. So we look at municipal wastewater, and you can actually detect some of the COVID virus in wastewater. And we have about 25 different wastewater networks across the state that gives us an idea of what's going on. And this is, again, it doesn't require testing for everybody, and it's a little bit of an early warning. So we're tracking this. You can see that last week to this week, we've had a little bit of an uptick in our wastewater, and that on the top left, it helps you to just explain what this graph looks like, but we're still far below the big surges that we've seen in the past. So you can see that big surge in January. That was when Omicron came and really surged throughout the state. So we're seeing a little bit of an uptick, which we expected, especially with some of those newer variants, the BA2 that you may have been hearing, but we're still at a relatively low level, which is good. On the right-hand side, in North Carolina, we get data feeds from all of our emergency departments across the state, which is an enormous gem of North Carolina. Not every state has that. In fact, very few states have that. And we're able to track emergency room visits for people with COVID-like symptoms. And you can see that we are at a relatively low level and pretty stable for people needing emergency department care for COVID. So these are two of our early warning indicators. Then we also look at our case counts and our hospital admissions. Our case counts, this is specifically people who have lab reported cases for COVID. We know this is an undercount. We know there are a lot of cases that either don't get tested or people do at-home tests and they're not reported. So we know this is an undercount, but it really helps us look at trends. So we look at this and you can see a little bit of an uptick in the trends in cases, same way that we saw an uptick in that wastewater, that we expect our wastewater and our case trends to move together. Again, we are seeing an uptick in our cases, but far below that what we saw during our Omicron surge. And then with our hospitalizations, thankfully, we are not seeing an uptick in our hospitalizations. Hospitalizations, it's typically a lag about 3 weeks or so between when you start seeing an uptick in your cases to when you see hospital admissions. So we still may see an uptick in our hospitalizations in a week or two, but we are maintaining relatively low hospital admissions for COVID, which is really, really, really nice. And what we've been seeing in other countries and other part of the country is that even with cases, because of this baseline level of immunity, even if people get infected, there's lower risk of them getting really sick and therefore lower risk of needing hospitalization. So we're tracking that pretty closely, but we are okay for now in terms of our hospitalizations. The CDC also has new metrics now that look at the community levels, and this is a combination of cases and strain on our hospital systems. And so we make sure that you have this CDC map, and you can see that they categorize counties in low, medium, or high in terms of cases and strain on the healthcare system. None of our counties are in high risk, yay, and only one county, which is Alamance this week, popped up into the medium range. But overall, across the state, we're doing pretty well. And then two other pieces. One, we track our vaccines and boosters. A vaccine and booster are our #1 way to protect people and especially decrease their risk of hospitalization and greatly decrease their risk of death if they were to get infected with COVID-19. So we track our vaccination and booster rates. We're really, really, really working hard on people making sure that they are fully boosted, especially if you've had their primary vaccine. And then finally, one of the things we want to also make sure people are aware of is what's on the horizon. What we've learned from COVID or SARS-CoV-2, which is the virus that causes the disease COVID, this virus is very good at shifting and having all these variants. It's very, very, very good and rapid at shifting. And as we see these different variants, then sometimes we will see these surges with the new variants. That's what we saw with Omicron. That's what we saw with Delta. And what I alluded to was the original Omicron has now shifted to what's called BA2. It's a subtype of Omicron. You can see that represented in the yellow. And we were a little bit nervous that in this shift to BA2, we might see another big surge in cases. I think the shift to BA2 is what's giving us that little bit of an uptick in our cases, but so far it's been pretty modest. But really wanting to make people aware of what's on the pike or what's down the pike and what variants are we seeing. It gives some nice forecasting and contextual environment for people to make decisions on. So those are some of our new metrics. Again, want to make sure people have all the information we have as they start making decisions for themselves and think about how many layers of protection do I want to apply. Maybe people who have had their vaccine but not their booster yet, and they start seeing the uptick in cases. So maybe this is the time they say, all right, I'll get my booster. Or for those people who are eligible for a second booster, including people over age 50 or people 12 and over with underlying immunocompromising condition, they are eligible for a second booster. So they say, well, now that I'm seeing these cases tip up, this is now the time for me to get my second booster. So just want to be sure people have all that data as they're making those decisions for themselves. So I'm going to stop there because then the next slide is I'm going to talk a little bit about recovery and some of our priorities for recovery. Let me just stop there and ask if there are any questions, anything specific to our current metrics and what we're seeing right now. And I see a hand, so go ahead. But I think you're on mute, Robert, you're on mute.
All right, can you hear me?
Yes.
All right. Dr. Tilson, is there any either general or specific measurement that weighs your immunity if you have you're fully vaccinated versus simply been infected? Is there any measurement that says, you know, you're 50% better off with the vaccinations or 30%? Is there any kind of metric?
There isn't, and for a number of lots of reasons in there. So first thing, we do know that if you're vaccinated and especially boosted, and or you've had a past infection, you do have some level of protection. But on the individual level, how much that is and how much it is in comparison to each other is very difficult to say. For an individual specifically, looking at the strength and the length of protection from a past infection, there's several things that go into that. One, what we do know overall is that most people are pretty well protected for 3 months after that initial infection, and probably up to 6 months, pretty good infection against reinfection within that 6 months. After that, it starts getting a little bit heterogeneous, and the strength of that protection starts getting pretty iffy. The other piece is that what we're learning is that people that had a more severe disease, especially those that needed hospitalizations, tend to have stronger protection than those people that had mild symptoms. So there's a lot of heterogeneity amongst the length and the strength of protection from a prior infection. With vaccines and boosting, we have more homogeneous data on the length of that protection, and most people generate about the same response of protection from vaccines and boosters, and it's more variable from a past infection. But one thing we do know, or we're learning, I should not say no, because we continue to learn with this virus, is that one of the best combinations can be people who've had a past infection and then that get vaccinated and boosted. It helps to stimulate different parts of the immune system, and those people seem to be the best protected, having the natural infection and vaccine and boosting. That combination together is some of the best you can get.
Thank you.
You're welcome. I wish I had an easy, we get that question a lot. I wish I had an easy answer, but I think one thing we've learned in COVID is nothing is easy and straightforward. All right, Robin, is that Robin Lane?
Dr. Tim Lane.
Thank you very much, Elizabeth. Yeah, all transparency, I'm an infectious disease doc, retired, and hopefully immune.
I'm having a hard time hearing you. I can hear, I heard infectious disease, hopefully immune. That's what I got.
Yes, and retired from practice, so I'm no threat to anyone, and fully vaccinated. The data that you had from the blood donors is really impressive, 97%, and it just shows you, you know, what I mean. Here's a living example of volunteer bias. People who volunteer for things get vaccinated, they don't smoke, they go to Chapel Hill, not to Duke, you know, the right things in life, they make the right choices. Do we have any cross-sectional data on antibody prevalence, you know, taken at random in any way? I'm sure the NHS, the National Institute of Health National Health Survey will do that in the coming year or two. Whenever they are due for their reporting, we'll draw blood in a random fashion, so we'll have better data. Do you know of any other data suggesting more?
Yeah, I'm having a very, very hard time hearing you, but I think I got your question. I think your question, and you're right on, is that some of the data we have from blood donation, that really high level, you're right. I think that's a huge selection bias. The people who choose to give blood, we probably have a very different, may have a selection bias from the population as a whole. I think you're absolutely right. We do have some, we're working with some community partners in North Carolina specifically on community levels of antibodies, like in Chatham County, we're doing some research with that community, as well as in Winston-Salem, in a little bit more of a cross-sectional. What we see is not quite as high as 97%, but about in the 80s or so, mid 80s, and that's a little bit. Now there might still be a little bit of a selection bias for people who are agreeing to participate in the study, but it's about 80% or so in those cross-sectional studies in North Carolina. So still, you know, quite high.
Thank you. Just one more comment. Can you hear me all right? Am I speaking loudly enough now?
Yeah, a little bit better now. Yeah.
Okay, good. You know, most of the unvaccinated are in rural counties where we're not, where, you know, the medical team, public health, are not doing sero surveys. So we may have a lot of potentially susceptible people in our state, in the millions. So if BA2 is anywhere near a fraction of Delta, we may see, you know, this is all guesswork, we may see in the early summer months things we don't want to see, uptick in hospitalizations and death.
Yes, and I think what we've learned is we can never really let our guard down, that we continue to see a threat, especially with our unvaccinated people. Our unvaccinated people are at the highest risk of infection and much more highest risk of severe disease, hospitalization, death. I think what we're finding is that some of these variants rip through our communities so quickly that amongst our unvaccinated, they have very high rates of infection. Even if our unvaccinated people aren't, they still may have some immunity from past infection. Now, it's not as protective, and we have some good data, especially even within North Carolina, that your risk of dying, you have about a 20-time higher risk of dying if you're unvaccinated as opposed to vaccinated and boosted. So I think amongst our unvaccinated, a prior infection may blunt some of that, but it's not going to blunt it wholly amongst as opposed to our vaccinated and boosted. But I think you're right. I think we still have a lot of unvaccinated people in North Carolina. So we don't want to take our eye off the ball. There's still a threat. But I think it will be blunted because of the amount of past infection, especially with Omicron. Whew, we had such high rates of infection with Omicron. It's going to give people some, at least, baseline protection. All right, let's see. Robert, you had another question, or is that up from past?
No, just slow on the uptake. I'll get that off.
Okay, terrific. All right, well, let me move on to recovery. So we really want to think about how do we move towards recovery, focus in on some of those population and public health concerns that pre-existed COVID, but has been exacerbated by the pandemic. We want to lean in on some of the values and activities that we did before COVID and during COVID. So continuing our robust partnership on the ground with our local partners. In North Carolina, we're a very decentralized system. We can do nothing without our community partners, our local partners, our local health departments. So we're continuing to work with our partnerships, continuing to try to earn public trust. That has been hard at times during the pandemic, but continuing to try to earn public's trust through transparent communications, and then continuing to evolve as we learn more. We'll continue to shift our policies, which we've been doing over these past 2 years, continuing to learn and shift. So we'll continue hopefully to work under those operating principles, but we're going to be focusing in on 3 areas that really have been exacerbated by the pandemic. Our behavioral health, mental health needs, substance use disorders, all predated the pandemics, but we know they were exacerbated during the pandemic. Before the pandemic, responding to the opioid crisis was a big focus of ours. And unfortunately, we saw a 40% increase in opioid deaths during the pandemic. We know with any downturn, any crisis, our mental health, substance use disorders are exacerbated. So we have a lot of more work to do in our behavioral health area. Children and families. Our young children and families were really devastated by this pandemic, not only in mental health, but also social economic factors, schools. And so we're going to focus a lot on our children and families. And then with our workforce, our early childhood workforce, our healthcare workforce, our direct provider workforce, and our public health workforce, who have really been under assault for the past 2 years, really thinking about our workforce. There was a study that came out from the Du Beaumont Foundation just about a month ago that showed more than 50% of our public health workforce had at least one symptom of post-traumatic stress disorder, having come through this pandemic, and us relying so much on our really historically underfunded public health workforce. So these are some of the challenges that were exacerbated by the pandemic. And so we're going to really focus in on them as we move forward. In our behavioral health, we want to be sure that we're addressing people in crisis, and that if the pandemic really tipped more people into crisis, but we also want to think about upstream and resiliency, and what can we do with building the resiliency of our families, of our communities, to really blunt some of those public health crises. So we're doing some work in that, especially again in ensuring that there's availability of our crisis response system, and investment in our upstream public behavioral health systems. In our child and family well-being, we are actually, even at the department, we are creating a whole new division specifically dedicated to children's and family well-being. We're putting together what's the plan that we need to really invest in our children and families, and in a cohesive manner, making sure that our behavioral health, our social services, our public health, Medicaid are all together, wrapped around that family, instead of the family having to intersect with all the services in a very fragmented way. Then we want to be sure that we have a strong and inclusive workforce, making sure that everybody can have a role in our workforce. That means people who may have been historically marginalized from our workforce, people with intellectual or physical disabilities, making sure that we are building, again, back up our healthcare workforce, and then investing in our public health workforce as well. A piece of this too is that we also want to think about our health insurance gap. One of the things that we struggled with during the pandemic is we're trying to fight this with both hands tied behind our back, with our large percentage of our population uninsured. So one of the priority levers that will address all three of our priorities is really working to close that insurance gap and moving to Medicaid expansion, which will really help us address the needs of our population, especially during this recovery. I got ahead of myself on this one, yay. So this is a really, really, really powerful lever. It's not going to be the end all. This isn't the only thing that we can do, but it's a really important lever to really help us be able to move forward on our recovery metrics. Our Medicaid expansion really helps ensure and improve the health of our lower income populations, especially our rural residents. Somebody talked about some of our rural residents, 40% more likely to be uninsured. And really just study after study after study has showed us that Medicaid expansion can lead to improved health outcomes amongst a whole variety of metrics within our healthcare system, as well as our health. One notable, just being a pediatrician, that reductions in infant mortality and reductions in disparity in infant mortality, you can see really strong decreases in that by having Medicaid expansion. So that's going to be something that we're going to be thinking about as an undergird to all of our priorities. Okay, and the last two slides, and then I'll stop and we can chat, is this concept of whole person health. And when I talk about whole person health, I mean behavioral health, physical health, and social health, or the social drivers of health. And very often our social drivers of health have been disconnected from our healthcare, even though the social drivers of health really affect about 80% of our health, 20% from healthcare, 80% from social drivers. But these two systems, the systems of social services and healthcare, have been historically separated and siloed and insufficiently funded. So this is an area that we were focusing on before the pandemic. We used some of our framework and lessons learned before the pandemic. We applied them during the pandemic, and now we'll be using lessons learned to apply those after the pandemic. And again, you all probably know this data, but 80% of our health is driven by non-medical factors. We want to be sure we're thinking about that, investing in that, integrating that. We really were an early adopter of strategies to scale, to do statewide scales of addressing our social drivers of health and connecting healthcare and human services. We will, in the next slide, I'll show you how we're continuing to invest in that statewide infrastructure. Great. So this is a place that we really, North Carolina really was leading the nation before the pandemic. And again, we were able to rely on some of this infrastructure to help us respond to the pandemic. We have built a number of very pragmatic programs and factors to, again, connect our healthcare and human services. You'll see in these concentric circles, the dark blue are those infrastructure and elements that can apply to all of our population. That kind of middle blue are things that we have rolled into Medicaid managed care. And that lightest blue is a really, really exciting, innovative opportunity we are allowed to do as part of North Carolina's move to Medicaid managed care, which is these pilots that we'll be able to do, which I'll talk about. But first, in this dark blue, this is some of the statewide infrastructure we wanted to build for all populations that then different organizations and agencies could innovate on top of. First one is NC Care 360. We are the first state to build a statewide infrastructure for coordinated communities. And so it's a statewide digital platform that connects healthcare and human services and allows those providers in both those sectors to make referrals back and forth in a connected way and a closed loop referral, so that I, as a medical provider, if I'm seeing a patient, the patient says, I don't have food, I can't, it's hard for me to control my diabetes because I don't have food. I can then make a referral to an organization that helps to provide food for that person. And I can see that, and I can see in a closed loop fashion what happens. And then when the person gets to the food service organization, they may say to the food organization, well, this is great, but I can't get here because I don't have a car. And so then the food service organization can then make a referral to transportation. And then everybody in an ecosystem can see that. Now I can see, okay, now this person has food and now has help with transportation to get to food. And we can create this whole ecosystem of health. And so we're very excited about that individual, that unified platform that different agencies can innovate on top of that. We have standardized screening questions that ask about food, housing, transportation, and interpersonal violence. So we are detecting those unmet social needs in a much more rigorous way. We've developed our workforce to work in this health and in this space, including our community health workers, which are great workforce for this very holistic health. We have some maps that really look at our hotspot across the state of where are our highest need of social drivers. And then we really utilized a lot of this framework during COVID to get people social supports to allow them to do isolation and quarantine. Remember, if we told people, we said, stay home. If you have COVID, stay home for 10 days. If you've been exposed to COVID, stay home for 14 days in quarantine. Well, if you are somebody who doesn't get paid, if you don't go to work and you stay home and don't go to work, then you don't make money, and then you can't feed your family, and then you cannot pay your rent. That is really hard to isolate and quarantine for people who are on that margin and can't do remote work. So we were able to use a lot of this framework to provide social support for those people, to allow them to isolate and quarantine, that helped with their individual health and help with the health of the community as well. And so we've done a lot of lessons learned on that. Within Medicaid, this is a huge powerhouse of a payer, and we can utilize healthcare dollars to pay for health. And so we're doing a lot of things within our move to Medicaid managed care, including rolling in a lot of requirements in our contracts with our Medicaid managed care plans, really incentivizing them and supporting them to use some of those dollars to pay for some of these the food and housing and social services as well, and make it be a way that it is in other states. There's a financial disincentive to do that. We're creating our plans such as a financial incentive to do that as well. So we're excited about that. And then finally, we're really excited about all of it, but our move to Medicaid managed care, the vehicle we did is called an 1115 waiver. We had to get permission from the federal government and negotiate with the federal government, but it gave us a flexibility that in 3 regions of the state, we are able to utilize up to $650 million to pay for infrastructure build and for actually services in food, housing, transportation, and interpersonal violence, that we can actually use our Medicaid dollars to pay for these health services. I'm really excited about that. We launched it in March with food, and then we just launched with housing and transportation, and we'll be launching those domains and following that for the next couple of years. So I'm really excited about that. And some of the big goals with this will be really how we define, deliver, and finance health. And we have a very rigorous evaluation because we really want to learn from this in order to inform our broader policy changes, not just in North Carolina, but nationally. And again, we're going to be integrating these non-medical services into our medical programs, Medicaid program. And then, as I said, we have robust evaluation to see how is affecting the individual health of people, promoting health equity, and then reducing costs for our Medicaid program. And so we're very, very excited about that and the rigor of that in order to learn how we can actually buy health, which we've talked about a lot, but pragmatically, how do we do that? So we're very excited about that. As I said, we're kicking off. We kicked off with food about 6 weeks ago and just with housing and transportation. Okay, so that was a fair amount in terms of recovery, go forward, and how we're going to pragmatically do that. So let me stop sharing my screen, and then we can all see each other, and then happy to take questions about any of that. Wayne, I see you in person and your little yellow hand. So
I'm a retired family medicine residency teacher, so I'm certainly have seen the ill effects of non-healthy opportunities, and really want to believe in this concept. The thing that I'm seeing not only with Medicaid managed care, but also with Medicare Advantage plans and the more recent investor-owned entities, they're, if you look at their websites, they're, really touting this, social determinants of health approach, but they're also saying that they're going to be paying their investors handsomely for doing this, and that's where my skepticism comes in. So I'm very heartened to see your slides, and it's a great presentation overall, I have to say. But I really appreciated seeing in your slides that you're going to be carefully measuring these outcomes. And of course, we all know that the bottom line outcomes, birth outcomes, et cetera, are what we most care about, not the intermediary outcomes. But I just really hope that the rules won't be changed during the measuring process so that we, are not able to see the fact that money's actually just being shifted to paying investors rather than actually making people healthier.
yeah, you make a really great point. I think that as weird as it is, the kind of like sexy topic now is social drivers of health, right? And so now, like, everybody's in, it's like, really, we've been talking about this forever, but now it's kind of gotten the traction. And so I think you're right. And I think the beauty, though, however, of we're doing it right within Medicaid, right? There's no investors in Medicaid. It's us, right? This is the federal and state government. And we are working really closely with the SHEP Center. So the UNC and the SHEP Centers will be doing the evaluation. So there'll be a nice kind of separation and validation of that. And we're going to be doing some rapid cycle evaluations. So with some more processy rapid cycle evaluation as we go through. There'll be yearly evaluations, and there'll be a nice summative evaluation that we actually hope will be able to get us even more granular to what a person with what risk factors, what services or combination of services is best suited for that combination of risk factors, and how does that affect health and cost outcomes. So it's a pretty rigorous evaluation that I don't anticipate changing because CMS has already signed off on it. We have the 70-page robust evaluation. So I think we'll be protected from some of that, that private pressure, and we're trying to do it as rigorous as possible. So I don't think our pilot will be threatened by that, but I think you raise a really good point. It's kind of a strange point now that this is the kind of sexy thing is social determinants of health. And so we're seeing a lot of that in. And so I think there will be some experimentation, especially in the for-profit setting, but I think ours will be rigorous enough that we'll be able to withstand some of that commercial pressure.
Thank you.
Yes, yeah. Robert, is your hand still up or do you have another question?
My hand is still up, but the microphone's not working, so I put the question in chat.
Oh, okay, hold on, let me see. How and what would you suggest as ways that the league can help? Oh, that's a great question. So a couple things. One, as I alluded to in the middle, there are so many things that we can do, but one of the most important fundamental levers that we can pull to really accelerate all of this work is Medicaid expansion. And it's a politicized topic, but when you look at the facts, we're one of very few states who haven't done it. Second, it incredibly improves the health of people. 3, it will not cost North Carolina a dime. The way that it's being proposed, federal dollars, and then there's a hospital excise tax that will be, the hospitals will help to finance the piece that isn't financed by the federal government. So it will cost North Carolina nothing and will incredibly not only improve health, but be able to be a huge economic driver. So of all the things I would say is if you can help advocate for Medicaid expansion, that would be an incredibly important value add. And if we could get that moved in North Carolina, it would help so much all the things that we are doing. So that's the first thing. Second thing is I would say, depending on your stakeholders, again, think about those 3 priorities: behavioral health and resiliency, early childhood and family, and healthy or a strong and inclusive workforce. Where are your stakeholders, or are you stakeholder to any of those 3 buckets? And make sure that people know those are our 3 priorities and we're working to advance those, because the more people we can get around aligning around those priorities and moving forward in those priorities, then the more progress that we can make. So those would be my two S's: Medicaid expansion, think about our 3 priorities, and think about how you can align your stakeholders in advancing those priorities.
Great, and I'll tell you, there are many members in the league who are on Medicaid expansion full bore.
Great. Yeah, and all public health is politicized, and I get that. But when you really look at it, golly. And there's also, just so you all know, there is an offer on the table right now out of the Treasury that says that any of the states who haven't chosen to expand Medicaid, if they do choose to expand Medicaid, you get like a signing bonus, and it's in the order of $1 billion that North Carolina could get if it chose to expand Medicaid now. So it is just, this is the time. Oh, this is the time. It will cost North Carolina nothing. We'll get, I think it's at least $1 billion if we do it. And it will just help to move the needle on and everything so much more, and help shore up our economy. And at the time now in recovery, this is the time to do it.
Dr. Tilson, my official raise your hand button doesn't seem to be working.
Oh, okay.
But I have a question. We know that during the height of the pandemic, we lost a lot of the workforce, the nurses in public health, nurses in hospitals and long-term care facilities. Are there any concerted efforts to rebuild our workforce?
Yeah, they are, and that's in that 3rd bucket, right? And so we think about the 3rd bucket of the strong and inclusive workforce. It includes healthcare workforce, public health, direct service providers, folks, again, who are marginally, are folks with disabilities who've been marginalized from the workforce as well. Those are some of our key priorities. AHEC and IOM and us are working together. There's a new, we're establishing a North Carolina Center for the Workforce on Health. And we're thinking about how can we organize that to really, because there's a lot of workforce initiatives, but it's a little bit more manufacturing, and how do we really think about the health workforce, right? Not just healthcare, and I'm looking at you, but the health workforce, and thinking about public health and direct service providers and nursing. So we're trying, it's such a big area, and we're trying to think about what does the plan look like, but we are working pretty closely with the IOM and AHEC and us. And Merle, if you know Walker Wilson, she's
Yes.
our lead at the department to really think about how we're integrating with that. And for sure, nurses and direct service providers are key in there. And the community health workers as well. It's just that's just a lovely, lovely workforce to think about.
Beautiful.
So lots of work to do there. If you have interest, I can connect you with people who can help.
I think I will give Walker a call, actually. And
Yeah.
I talked to some people last week about it too, so.
Yeah, and we actually just had a meeting this morning with AHEC, just trying to think about how do we coordinate all of this. And you know, we have some CDC money specifically about the public health workforce, right? And so we're trying to integrate that in, and then the healthcare workforce. So
Beautiful.
Yeah.
Thank you.
yeah, my pleasure.
Actually, if no one else has a question, I actually have one more on a different topic that you mentioned, and that is the sewage treatment plant. What did you call that?
Oh, the wastewater. Yeah.
The wastewater, which I know that some communities in our state are participating in the wastewater testing. Can you tell us more about that? You know, do we have small and large, rural and urban, and how that's going?
Yeah, and I can, if you're interested, I can send you the map. We have about 25 different sampling sites across the state. They're a little bit more in the in some of the urban areas in Wake and in Mecklenburg, but we have some that are a little bit more rural. But excuse me, that's a hard word. It's municipal water, and you remember a lot of our rural folks are on well water, right? So it's not as robust in our rural areas because they are on septic. They're not municipal, so it's municipal sewage. So that limits us a little bit. But we have about 25 sites across the state, geographically spread out pretty well. But again, it's municipal water, so it restricts us a little bit to those little bit more urban areas as well. The 25 sites. If you're interested, I can send you the map. Zach Moore and Erica Wilson are, and we really were one of the first states to start it. We've been doing it for now more than a year and a half. We were one of the first sites and one of the most robust sites to have that. Yeah, it's pretty cool.
Thanks.
Laurie, go ahead. You're muted.
Oh, thank you. Dr. Tilson, you may or may not know that the League's position on the whole subject of healthcare is that we believe strongly in a single payer system that covers every resident of the United States. And I just wonder, do the practices in other countries with regard to promoting health before we have to take care of illness and injury, are there any other countries that already do this pretty well? And what have you learned from them, and how has that been incorporated into your plan?
Yeah, so overall, when you look at countries similar to ours, almost all of them have universal health coverage. Right, we're an outlier, and overall health status is better than those countries than in the United States. We rank pretty low in terms of our health outcomes as opposed to countries similar to ours in terms of size, GDP. So we have lots of examples of other countries who, again, have universal insurance and have much better outcomes, likely due to it. And there's another data point in there that when you look at, a lot of people will show you a graph that looks at the amount of dollars that are spent on healthcare and then where our health status is. You'll see United States pays more dollars on healthcare than any other country. But when you look at the dollars spent on social services, when you look at overall the dollars spent on medical care and social services, the United States is actually kind of in the middle. But what's really, really notable is that when you break down that total of medical care and social services, our ratio of medical care is much greater to social services than other countries. So it's not that we spend that much more on medical care and social services, it's just that our ratio is off and we spend way more on medical care than social services. And if we could get that balance right, which is kind of what we're trying to do in the pilot, if we can start thinking about, let's use our healthcare dollars to pay for food and housing that will offset the medical dollars, then we're not spending any more money. We're just spending it in the right way, and then hopefully will get us to better health outcomes. So those two factors, again, universal health insurance in other countries, we rank poorly in terms of health outcomes, and how we're investing our dollars is also off, that we can get that investment right. It could help to improve outcomes. And so I think there's a lot of different ways that we can get at improving health. I don't know that it has to be one universal insurance coverage. I think Medicaid expansion and getting more people insured is a great, pragmatic, on the table right now solution that we could do. And then investing, how do we make sure we're investing our dollars in the right way within that? So that's what I would say.
Thank you.
Yeah.
And Dr. Tilson, I'm going to follow up on Dr. Hale, Wayne's question. He always reprimands me when I call him Dr. Hale, but Wayne's question. Tell me, I'm looking for your personal evaluation, because, you know, we're dealing with this managed care issue, both in Medicaid and in Medicare. And of course, a lot of it gets down to how you're reimbursed with value-based judgment versus fee for service. So what are your thoughts in terms of the dangers of value-based judgment, the benefits of it versus, and we know there are problems, of course, with fee for service too, but just wanting to know what you think and what your assessment is.
Yeah, I think overall, moving towards a pay for value, or moving towards advanced financing mechanisms that allow us to pay for health is the right direction to go, right? What we want to do is be sure that we are using our money and holding ourselves accountable for improving health in a flexible way. Our fee for service locks us in, locks our providers in. It's just not the way to go if we really want to buy health. So I think that direction is the right direction, but there can be a lot of unintended consequences as part of that move. And so, for example, some of the things that we're doing to try to mitigate some of those unintended consequences as we move to managed care is we have very tight accountabilities. We have very tight metrics. Our metrics are really aligning to improving health outcomes. So I think it's the direction we need to go to, but you have to be sure you're putting in guardrails and you're putting in lots of accountability, that our plans are really incentivized to improve the health of people, and not to just make money, but that they're really incentivized to improve the health. So it's the right way to go. There's lots of mischief in the process. And so again, at least in our move to Medicaid managed care, we've been so mindful of what's the oversight, what are the metrics, what are we, and then again, and making sure the incentives, that our plans are being incentivized to do the things that we want them to do, and thinking about all those mechanisms to keep people in the right direction. I'm not going to say it's not going to be perfect. I'm not going to say that people are going to find ways, but I think you can put up guardrails to make sure that we're all moving in the right direction.
Thank you.
You're welcome. Well, I do have a hard stop at 1. I just realized what time it is. So I'm happy to take, if there's any other questions, that's great, but I do have a hard stop at 1, and I just realized it's 12:59.
Well, thank you very much for giving us your time. We appreciate it tremendously, and we will share this with other people who are interested. Thanks a whole lot.
Beautiful.
Wonderful. All right, well, it was my pleasure.